Welcome to the second module in the Clinical Faculty Pedagogical Knowledge for Undergraduate Medical Education program. This module will summarize strategies for clinically based assessment and providing feedback for learners. Assessment is often described as a continuum between formative assessment and summative assessment. Formative assessment is about providing feedback to learners to support or enhance learning. Summative assessment is about measuring and documenting learner achievement for the purpose of assigning grades, informing decisions regarding progression in the program, or justifying certification. Formative feedback is about sharing information with the intention of improving learner performance, while summative assessment is about providing a judgment about a learner's progress to date. Feedback should be delivered in non-judgmental language and based on what a clinical educator personally observes. It's described by Cantillon and Sargent in 2008. Clinical educators are often asked to make both formative and summative assessments in providing feedback to their learners. How a clinical educator balances formative and summative assessment is an important consideration for clinical educators to provide effective, meaningful feedback to their learners. Clinical educators often feel uncomfortable and have difficulty providing learners with direct, behaviorally based feedback regarding performance, as described by Bruckner et al. In 1999. Learners need effective feedback from clinical educators. Learners are usually enthusiastic to receive feedback. However, there are several barriers that prevent providing effective feedback. Learners are uncomfortable seeking feedback directly from educators. Learners have different levels of skill in self-assessment and may not be aware what is important to learn and what to ask for during feedback. Educators are often not aware of what methods are available for making assessments and providing feedback. Clinical educators often have little formal faculty professional development in assessment and feedback and are uncomfortable providing specific feedback. Clinical educators often are uncomfortable sharing their observations or hurting the feelings of the learners. Some clinical educators lack skill in translating observations into specific constructive feedback that is actionable by the learner. Feedback is often given in general terms and not helpful to learners. When clinical educators believe their feedback to be detailed, learners often find the feedback inadequate, again as described by Bruckner et al. In 1999. Cantillon and Sargent in 2008 presents a summary of strategies for giving feedback in clinical settings: the feedback sandwich, the Pendleton model, and the reflective feedback conversation. We will explore each in the next few slides. Clinical educators are more comfortable giving constructive or corrective feedback if the approach used is less likely to embarrass a learner. Cantillon and Sargent in 2008 described the feedback sandwich as an approach to giving constructive or corrective feedback. The feedback sandwich ideally should be a conversation rather than a one-way transmission of what the clinical educator thinks about the learner's performance. In a feedback sandwich, the conversation begins with a reinforcing statement regarding something specific the clinical educator observed the learner did well during the clinical encounter. The reinforcing statement is followed by a corrective statement, or a statement that includes some specific area that the learner could improve in the future. Cantillon and Sargent advise against transitioning from the reinforcing statement to the corrective statement with the connector "but," as students will focus on the corrective statement and forget the positive message offered by the reinforcing statement. The feedback sandwich is completed by a second reinforcing statement that includes another specific thing that the learner did well. The feedback sandwich is most effective when the feedback is given by a clinical educator that includes specific information about a clinical encounter rather than general observations. Feedback that is specific and actionable are most effective. A busy clinical service may reduce the effectiveness of the feedback sandwich approach. When busy, it is easy for clinical educators and learners to focus on reinforcing statements with fewer corrective statements. It is important to address areas of weakness even if these areas are minor. In a clinical setting involving more than one patient encounter, the clinical educator could provide a separate feedback sandwich for each encounter that is specific to that encounter. As the learner sees more patients, the clinical educator can link what the learner did in the earlier encounters with current performance. Cotillion and Sargent recognize that the feedback sandwich is based on behaviorism learning principles, where the teacher holds the power and directs the structure of the learning experience. This imbalance can be reduced when the clinical educator delivers the feedback sandwich statements, invites the learner to discuss the feedback, and then together form a plan for future action. The next model extends the feedback sandwich to more explicitly include the learner in the feedback process. This is the Pendleton model. The Pendleton model was proposed in 1984 as a method to assess resident physicians in their first year of training, interns, and has been adapted for other educational settings. Cotillion and Sargent describe the Pendleton model as a structured approach to a conversation between a learner and clinical educator regarding the learner's performance. This approach is different from the feedback sandwich as the learner's comments on his or her performance precedes the clinical educator's observations. The model consists of 4 essential steps that are described in this slide. Step 1, the learner states what was good about his or her performance in the clinical encounter. Step 2, the clinical instructor states in what areas he or she agrees with the learner's self-assessment and adds his or her observations regarding good performance. Step 3, the learner states what he or she did that could be improved. Step 4, the clinical educator gives his or her observations on what could be improved. As this approach establishes a conversation and is less likely to result in a one-way transmission of information, learners have more of an opportunity to consider his or her own performance, for example, or in other words, using a cognitivism approach, and is able to interact with the clinical educator in a way to build on prior experience and knowledge to a higher level of performance, as we would see in social cognitivism. This slide contains a different perspective on the Pendleton model that includes the patient. The learner fits into this model by becoming involved in helping the patient understand why the patient is being seen, what other problems may exist, contributes to the plan of action from the problem list, etc. By having the learner participate in the doctor-patient relationship, the learner and the clinical educator will have more insight into how the learner is performing. Cantillon and Sargent suggested that the Pendleton model discussion occur in private setting rather than at the bedside or with a group of learners. Though the learner will have a more direct role in forming the feedback, Cantillon and Sargent recognize that the structure of the conversation may prevent an effective discussion where the learner's performance needs are addressed. If the clinical educator does not identify the deficits the learner did not discuss, then the learner will not have an opportunity to recognize or address these deficits. The next feedback strategy enhances and expands the feedback sandwich and the Pendleton model to include more self-assessment and critical thinking on the part of the learner, consistent with a cognitivism perspective, and a more detailed conversation with the clinical educator, consistent with social cognitivism, with the goal of increasing the learner's skill and knowledge base. This is the reflective feedback conversation. Silverman, Draper, Kurtz, and Silverman presented the Calgary-Cambridge approach to communication skills teaching in 1997. Cotillion and Sargent, 2008, described the reflective feedback conversation model as an interactive feedback approach that focuses on the essential goals of feedback, encouraging learners to reflect on their performance and to motivate learners to improve performance based on the feedback. This model includes the clinical educator-learner conversation from the Pendleton model, but places greater emphasis on the learner to recognize performance deficits and includes a plan directed by the learner on how the learner will improve. From the Calgary-Cambridge approach, the reflective feedback conversation constructs feedback in the form of an agenda that both the learner and the clinical educator agree. As described by Cotillion and Sargent, the reflective feedback conversation is structured by a shared agenda. For example, the clinical educator asks the learner to share concerns about a recent clinical encounter. The learner reflects and then discusses his or her concerns and what he or she would have liked to have done better. The clinical educator considers what the learner has shared and offers his or her view on what the learner has identified as concerning. The clinical educator offers support, such as recognition that the learner is not the only person to ever have had this concern. The educator considers sharing his or her own experience grappling with the same area of performance. The clinical educator asks the learner to consider what he or she could do to improve performance. Once the learner has reflected, he or she can then share his or her opinion on what could be done better in the future. The clinical educator expands the learner's response, making corrections to the learner's thinking as needed, and assuring that both the learner and the clinical educator understand and agree on a final assessment. Now the learner and clinical educator plan a next opportunity for the learner to demonstrate improved understanding and performance. The reflective feedback conversation model encourages learners to develop self-assessment skills and promotes a shared view regarding what improvement will look like. With practice, this strategy can be done efficiently in clinical teaching and learning. Educating learners to become competent physicians still relies on an apprenticeship model where learners gain knowledge and experience in clinical encounters working with supervision from clinical educators. Learners learn from watching clinical educators act as role models and from the feedback they receive on their performance in clinical encounters. The role of feedback is to help a learner move toward improvement in performance. This next strategy is adapting Spike's protocol for feedback. Thomas and Arnold in 2011 described giving feedback as an essential function within medical education. These authors identify parallels between discussing bad news with patients and giving feedback to learners, emphasizing the importance of adjusting the amount of information given, attending to the affect of the individual receiving the information, and making plans for next steps. Thomas and Arnold identify many parallels between communication skills used in difficult conversations with patients, such as palliative care settings, and providing feedback to learners in clinical care settings. The discussion takes place between someone in a position of authority, like a clinical educator, and someone who is more vulnerable position, like a learner. The information to be shared may be sensitive in nature. The recipient of the information may respond to the information with a wide variety of emotional reactions. Thomas and Arnold proposed the SPIKES, SPIKES protocol for delivering bad news in palliative care settings. The SPIKES protocol includes the following steps. Number one, set up an interview. Number two, assess perception of the information recipient. Um, Number three, obtain an invitation to give information. Number four, convey knowledge or information. Number 5, address emotion. And number 6, summarize and strategize what has been discussed. Feedback should be constructed with care and follow 3 principles. The first principle is that attention is given to the setting where the feedback will take place and what is the capacity of the learner to integrate the information provided. The second principle is concern for the learner's emotional reaction to the feedback. The clinical educator should be comfortable dealing with negative emotions. The third is to identify the learner's needs as a first step and then strategize steps for improvement. The clinical educator should be aware of the aspects of the clinical encounter that the learner experienced, the emotional aspects of the potential impact of clinical encounters on the learner. It is important to address the learner's communication skills without mixing a discussion about communication skills with aspects of personality that can give the impression feedback is an assessment of the learner's character. Learners may not have an accurate assessment of their own knowledge and experience and may not respond positively to feedback that questions their level of knowledge or skill. Framing feedback sessions as expected with clearly defined purposes helps to create a safe environment where the learners are less likely to feel criticized. Involving learners in identifying learning goals promotes a partnership relationship with clinical educators and, as in social cognitivism, encourages an increased sense of self-efficacy. Medical student evaluation and timely feedback during clinical clerkships are essential to providing a quality medical education. Evaluation can define a level of learner competence and can direct future learning. Evaluation can guide improvement effort for the curriculum. The RIME method was proposed in 1987 to evaluate and counsel learners with academic difficulty during clinical clerkships, as described in Ogburn and Epsey in 2003. Ogborn and SP in 2003 published this article with the intention of adapting the RIME method for use in evaluating medical students on their obstetrics and gynecology clerkship rotation. RIME is defined as reporter, interpreter, manager, and educator. Each component of the RIME method is defined by an objective framework that forms a basis for evaluation. This method can be used by individual clinical educators such as residents and faculty physicians. When individual evaluations are collected as data set, the RIME method can describe individual learner and group progress and programmatic effectiveness. The RIME method defines each level with specific activities the learner, in this case medical students, should possess to be considered competent at that level. A learner that is a successful reporter demonstrates competence and reliability in the collection and communication of clinical information. Reporter includes descriptive terms such as reliability, honesty, and professional qualities performing specific tasks such as history taking. Once a learner has completed the standards as a reporter, the next level is to become an interpreter. The descriptive terms applied to the interpreter are scaffolded onto those that define the reporter. An interpreter is described as independent, capable of critical thinking, managing data that either supports or refutes diagnostic impressions. Learners functioning at the interpreter level consistently produce reasonable differential diagnoses and create accurate problem lists with little guidance. The interpreter is also working on moving up to the level of a manager. In the RIME method, a learner becomes a manager when he or she is functioning with a high level of direct and active involvement in patient care expected for fourth-year medical students or first-year resident physicians. The manager level is beyond the expected performance level of most third-year medical students. A manager can recommend diagnostic or therapeutic plans and can work with patients and families to help them understand the reasoning behind those plans. A learner who is functioning as an educator demonstrates skill in self-directed learning and contributes to the education of fellow medical students, resident physicians, and faculty. Educators identify and ask the important questions in complex cases and resolve those questions employing self-directed learning skills. The RIME method for evaluation of third-year medical students define components that are attainable by these learners at the recorder and perhaps the interpreter levels. The manager and the educator levels are beyond the capability of most third-year medical students. The RIME method sees value in providing aspirational levels for learners, as learners should have some idea what level of competence is expected in the future and can begin working toward these higher levels early in their educational careers. Creative clinical educators can adjust the requirements of a RIME method level to fit a clinical situation or a specific learner. Espy et al. In 2007 published a follow-up to the Ogburn and Espy 2003 article. The RIME method provides a framework and vocabulary to provide meaningful feedback to learners when both learners and clinical educators understand and agree on what the descriptive terms under the reporter, interpreter, manager, and educator levels mean. This article emphasizes the RIME method is most effective when evaluation and feedback occur across a wide variety of clinical situations, observations by many clinical educators over time, prompt recording of results, and discussion of clinical observations. This system functions best when clinical educators provide evaluation and feedback for learners who they have observed the feedback is timely and actionable by the learner. With so much of medical education moving away from emphasizing knowledge acquisition and duration of training toward the achievement of learning outcomes and competency-based evaluation, learners are expected to reach defined milestones consistent with the performance expectations of competent physicians. Clinical educators are increasingly expected to provide evaluation and feedback that is prompt, focused on performance, and provides opportunities for improvement in the quest to achieve milestones and ultimately clinical competence. Romani and Krakoff in 2012 recognized that feedback is an essential function for preparing learners to become clinical practitioners. Behaviorism theory defines how clinical educators reinforce good practice habits while discouraging faulty practice habits among their learners in clinical education settings. The key to success is for educators to provide frequent and detailed feedback. Though many of the 12 tips suggested here are best established on an institutional level, many are helpful for the teaching practice of individual clinical educators. A respectful learning environment provides a positive experience for learners when the clinical educator and the learner are working together to help the learner reach his or her educational goals. That relationship is reinforced by the educator providing frequent and specific feedback with opportunities for the learner to demonstrate improvement with guidance. Educators should communicate goals and objectives for the learning session clearly. The goals and objectives then function as a framework for how feedback is structured. The educator must limit feedback to what he or she has personally observed the learner do. Feedback should be timely and frequent. After each patient encounter is optimal if possible. Beginning each session with the learner discussing his or her self-assessment of knowledge and skill will help the educator to select and direct patient care activities that will enhance the learner's knowledge and skills. Throughout the course of the session, the educator should reinforce desired behaviors and correct other behaviors. This is how a behaviorist approach can function in social constructivism context. The interactions of this type help reinforce that the educator and the learner are partners in taking care of patients and educating the learner. Communication is important. The clinical educator should consider sitting with the learner to reinforce their relationship as partners. Feedback should be delivered in a respectful, supportive tone with language that precisely describes the learner's performance in a neutral manner. To wrap up a feedback conversation, the educator should confirm the learner understands and accepts the intention and spirit of the feedback. The learner and the educator should agree on an action plan for the learner's future performance. As the learner is expected to improve performance through reflection and self assessment, the educator should do the same for his or her performance, providing assessment and feedback. The last two tips encourage educators to participate in creating feedback learning opportunities and contribute to an institutional culture that supports feedback that is timely, regular, and specifically directed to observed learner performance. The process of assessing and providing feedback is firmly based in educational theory. Behaviorism helps provide a frame for the assessment and feedback session. The session includes goals and objectives, a structure that the clinical educator sets for the learner, and deals with reinforcing target behaviors and correcting unwanted behaviors. Cognitivism provides guidance in keeping feedback focused on directly observed behaviors and providing actionable suggestions frequently to encourage learning. Social constructivism structures the interaction and relationship that exists between the educator and the learner. With these theoretical perspectives, clinical educators can perform and direct assessment and feedback in a way that is tailored to the needs of individual learners.